Greetings, I'm Elizabeth Ayebare, and I'm presenting our work entitled Healthcare Workers' Experiences of Managing Fetal Distress and Birth Asphyxia at Health Facilities in Northern Uganda. I'm a PhD student and I'm sponsored by the Sweden Makerere University Bilateral Research Program. By background, birth asphyxia is one of the leading causes of neonatal mortality worldwide, and it also contributes to the high intrapartum stillbirth rates that are observed. In many low-income settings, birth asphyxia is compounded by the poor healthcare system, and this reduces the newborn's chances of survival. We explored the health workers' experiences of managing birth asphyxia and fetal distress in order to gain a deeper understanding of the challenges in a low-income setting. We used a qualitative descriptive design by conducting in-depth interviews with 12 midwives and 4 doctors working in the maternity units. Our interviews were audio recorded, transcribed verbatim, and analyzed by content analysis. We independently coded the transcripts and identified categories. And after discussions, the final categories were agreed upon by all the authors. A study setting included 3 levels of healthcare that are in Uganda, and the Health Center 3 is the first level of maternity care. We also had a Health Center 4 and a hospital, and those are the particulars of the different levels of care. So we came up with 4 categories, and the first one was looking at the interventions for fetal distress and birth asphyxia. Healthcare workers described how they manage these 2 conditions, and they emphasized the need for urgency while managing fetal distress and birth asphyxia. We noted some misconceptions in the management, and one of them was the emphasis on intravenous fluid use, such as normal saline, when women had fetal distress, and this led to delays in referral in some instances. Health workers also reported several challenges while managing fetal distress, and these included the complexities of the referral system, especially when they needed to transport women to another level of facility. There was refusal of referral by the women who were not sure of what care they would receive at the next level, and lack of supplies and equipment and human resource challenges were also reported. We found that there were high expectations from the community on the midwives and the health workers that put them under pressure to perform. Sometimes they were blamed when there was birth asphyxia. However, the blame was sometimes also put on the mothers who had given birth. We sought to get some insights from the healthcare workers on preventive measures for fetal distress and birth asphyxia, and some of the issues that were mentioned included early antenatal attendance, delaying the age of first birth, since teenage pregnancy is very rampant in this area at 25%, and monitoring of women and the fetus during labor in order to prevent complications or manage them early. We therefore found that health workers face several challenges, and therefore we recommend that guidelines to manage fetal distress and birth asphyxia be tailored to different levels of health facilities in order to ensure quality of care and reduce the need for referral. We also think that innovative ways to operationalize transportation for referral need to be devised. Community dialogues and education to improve birth experiences and outcomes are necessary in this setting. Thank you.
Respectful maternal and newborn care in a hospital of Nepal. EN birth observation study. This study was conducted under the leadership of London School of Hygiene and Tropical Medicine, Golden Community Nepal, and Uppsala University, Sweden. Respectful maternal and newborn care is an important component of high quality care. Recent focus has been to improve provision of quality of care, but is also impeded by measurement gaps regarding experience of care. And to date, very little focus has been on constructing the metric for measuring the respectful care for newborns during the childbirth period. Every newborn birth indicated research tracking in hospitals. ER birth was an observation study with a mixed method used to assess the measurement validity for coverage and quality of maternal and newborn indicators. In this paper, we report the measurement of respectful care for women and newborns during childbirth from a hospital of Nepal method. This study was conducted in a referral hospital of Nepal, Pokhara Academy of Health Sciences, which delivers 8,000 birth every year. Um, in this study, there were questions asked to mothers during the time of discharge using an standard questionnaires on abuse and disrespect developed by Hill and Browser, and their experience. The study was conducted between July 2017 and July 2018. The question was based on 7 mistreatment typology during childbirth. We calculated the association between these typologies and determinants, including ethnicity, age, education, socioeconomic status, and mode of birth as potential predictor for reporting poor care. The disrespect and abuse typology were basically classified as abuse, stigma and discrimination, meeting standards, rapport between the woman and providers, and lack of health system support or conditions and constraints. During the study period, 4,290 women were interviewed um, in the study period, and none of them reported any physical and sexual violence and abuse. All reported being treated with respect and dignity, with no refusal of care due to inability to pay. Regarding the stigma and discrimination, 80% of women reported that their birth experience met their religious and cultural needs, and 84.3% of women were satisfied with the privacy being maintained. Reporting poor care was lowest uh, in women from relatively disadvantaged uh, ethnic group, Madhesis, and women with no previous birth, compared to women with previous birth having had poor reporting of care. Women who had cesarean birth were more likely to report poor care during childbirth than women who had spontaneous vaginal birth. In terms of the gaps in the measurement of respectful care at birth, exit interview surveys likely uh, can underestimate the negative experience of care even with an independent interviewers. Further research is needed to explore a measurement of more tangible events, privacy, companionship, separation, linked to other data sources such as service readiness surveys, assessing availability of single rooms, curtains, hand washing facilities. In conclusion, measurement of respectful care at exit interviews after hospital is challenging since even with independent interviewers, women tend to report 100% respectful care for themselves and their babies. Especially questions with stratification by mode of birth, women's age, and ethnicity, if appropriate, is important to identify those receiving less respectful care and prioritize action. More research is needed to develop evidence-based measurement to track respectful facility care, including zero separation for mothers and newborn diet.
The Imagine project is a collaborative interdisciplinary network with a shared interest in midwifery-led models of care. Our partners are in the UK, Brazil, Malawi, Sudan, and India. Together, we've worked to develop an ongoing research and development programme that aims to test whether the introduction of midwifery-led units, staffed by dedicated midwives, can improve the birth environment and experience of care for women and midwives in low and middle income countries. Midwifery-led care models can have benefits for mothers, for midwives, and for resource-constrained health systems, But we lack evidence of how these services may be implemented in low and middle income contexts and cannot simply extrapolate findings from high income to low income countries or across health systems. To address this, Imagine members carried out a rapid appraisal situational analysis in each country earlier this year to assess existing midwifery provision and service delivery, but also to explore a range of respondent perspectives on local priorities, possibilities and appetite for midwifery-led care, and to consult on the development activities and adaptations that might be needed if midwifery-led units were to be piloted in each country. We used collaborative workshops with two groups. Firstly, key representatives from Ministry of Health, policy, professional, educational and women's organisations and NGOs, and secondly, with midwives and other maternity professionals. We were able to complete this work in Brazil, Sudan and Malawi, but COVID-19 constraints made it impossible to carry out the planned workshops in India, limiting us to discussions and virtual meetings with our partners there. However, a documentary analysis exercise is still ongoing in all countries and will provide more data and insights. As you can imagine, pulling together the findings across 4 very different country contexts can be challenging. To capture the complexities and to make the findings more accessible, we've used an adapted version of the Consolidated Framework for Implementation Research to show you the domains that were covered in our data collection. When you look at the diagram on the poster, the outer setting captures the broader context in which birth services are situated. So it includes issues such as the impact of global policies and shifting recommendations on stakeholders' attitudes to birth. It also includes the dominance of the medical model of birth, which some stakeholders explicitly linked to women's unhappiness with facility-based delivery, or in Brazil, where 98% of births are obstetrician-led and caesarean section rates of 55%, the humanising birth discourse acts as a powerful catalyst for change. The inner setting lists some of the main factors that impact on the possibilities for midwifery-led units. Key themes here were the significant skill mix and capacity differences across countries. In Sudan, the majority of midwives don't meet the International Confederation of Midwife standards. In Malawi, most midwives are dual qualification nurse midwives, and their vacancy rates are in excess of 60%. Brazil has various cadres, but only a very small intake of direct entry midwives. And India is facing rapid change as it attempts to scale up midwifery training after facility-based delivery rose from 30% to 75% in a decade. The individual characteristics domain captures knowledge and beliefs about the possible introduction of midwifery-led units, but also includes the attitudes of those who might be part of an intervention, their feelings of self-efficacy and confidence in midwifery-led units, and their ability to provide woman-centred care, or other personal attributes that may affect implementation. Finally, the intervention characteristics domain reflects factors that can impact on success of any implementation project. These include ownership and sensitivity and adaptability to local context. All of these are key aspects of Imagine's ethos and lie at the core of the shared philosophy of birth that underpins our work. In addition, our proposed project will bring skilled midwifery care closer to the community level, where the majority of women in these countries live and birth, and this is a key consideration for policymakers and makes the introduction of midwifery units more attractive. Despite the contrasting midwifery contexts and service configurations, there was a strong appetite across these countries to use existing resources more effectively to improve birth services, with an awareness of the role midwifery-led units can play in providing respectful maternity care for women and improved job satisfaction for midwives. The situational analysis exercise demonstrates the complexity of working across diverse settings and the need for multifaceted approaches and engagement to have any chance of successful implementation. This work allowed us to understand the broader landscapes in which midwifery services are currently embedded and implemented, and to gather a wide range of perspectives on the possibilities for change. Our next steps will be to continue our work with country stakeholders to develop and design pilot projects, and our longer-term goal is to carry out a trial to test outcomes.
Every 2 minutes, a woman dies of childbirth or pregnancy-related complications. New solutions are needed to support antenatal care workers in providing high-quality services and reducing mortality. User personas are a human-centered design tool that help communicate experiences, behaviors, goals, and challenges of a user group to multidisciplinary teams. We created 2 personas, a community health nurse named Akasua who works at a CHIPS compound in the Brangahafa region of Ghana, and a midwife named Rakaya who works at a health center in the same region. These fictional characters represent the 38 community health nurses and midwives we interviewed, and their stories will be used by product developers to brainstorm solutions to identified challenges and make design decisions as ideas advance. In this poster, we explore the case study of challenges in preeclampsia screening at routine antenatal care visits and propose solutions with their product requirements that Akasua and Rakaya suggest to improve their ability to provide quality care. More information that can be applied to challenges and solutions in antenatal care more broadly can be found in the full version of these personas. Some of the major challenges that plague both Akasua and Rakaya include delayed care seeking in their community, language barriers, transportation issues, high workload burden, and limited supplies and infrastructure. Looking specifically at Akasua and her environment at a CHIPS compound, where she does not have access to a lab, Akasua must refer her clients to a higher level facility about 15 kilometers away for testing. The current system for recording and tracking client information relies on a paper-based ANC card. Akasua loses contact with her client and their results after the referral. At Rakaya's health center, she has a lab, but irregular access to urine tests needed for detecting preeclampsia. When tests are available, her clients wait in long lines to get tested for proteinuria, with tests that are often inaccurate or difficult to interpret on a colorimetric scale. But when there are no tests available, Rakaya relies on the danger signs of preeclampsia, like headaches and blurred vision, to refer for potential preeclamptic cases. Using the personas and fully understanding the context and manifestations of these challenges that ANC providers face lead us to develop solutions that are user-centered, more usable, and acceptable. The solutions all midwives and community health nurse interviewed were most interested in was digital tools. To avoid issues with pilotitis and poor scalability of mHealth apps, Akasua and Rakaya promote one tool to solve multiple challenges. Addressing issues with follow-up and referrals and limited supplies like ANC cards, a platform that houses client data is essential. The same tool ideally would have options for automated interpretation of urine dipsticks to ensure timely and accurate diagnosis. If this was expanded, ANC providers would be interested in task-shifting urine testing to their clients with the use of this interpretation feature. To overcome obstacles with language barriers, this tool should be accessible in many of the 21 languages spoken in this region, and include illustrative prevention and educational materials to support Akasua and Rakaya in counseling their clients on the next steps after diagnosis. This tool also shows potential for decentralizing care, addressing challenges with transportation, and expanding the quality and equity of ANC care. Overall, solutions like digital tools that are under development or looking for ways to be adapted to be more user-friendly should consult tools like personas to keep users and their needs at the forefront. We have confidence that these ANC personas will accomplish change in product and strategy design as we look at ways to reduce workload burden of providers and maternal mortality in this region. Thank you for taking the time to explore our poster. If you have any questions, please attend our Q&A session or reach out at dxinfo@path.org.
Hi everyone, my name is Diana Mbatude from Aga Khan University, Uganda, and I'm here on behalf of the team that carried out a study to explore the factors that contribute to stress and burnout among midwives in Uganda. Part of the team, Dr. Grace Edwards and Dr. Ahmed Mohammed Saki. So it's many studies in African settings have documented actions that are perceived as maltreatment to mothers and their families during pregnancy, childbirth, and shortly after that, and especially during childbirth. And these studies have looked at this from the perspective of the mothers, their families, and very limited studies have explored this situation from the perspective of the midwives. Midwives in developing countries work amidst challenging situations and circumstances that might impact on how they provide care to mothers. So we intended to explore the stressful factors from the perspective of midwives that might impact on how they provide care to mothers. Secondly, we wanted to identify issues that might impact on the provision of quality midwifery care to mothers, and also compare um, differences in responses between midwives that work in rural or urban settings, or those that work in private or public health facilities. So we conducted a cross-sectional survey in 4 health units in Uganda, and these 4 health units, 2 of them were in urban settings and 2 of them were in rural settings. And those in urban settings, 1 of them was public and 1 of them was private. And those in rural settings, both of them were public health units. So the health units included Kawempe Regional Referral Hospital, Chiboga District Hospital, and a health center, for which all the 3 are public health facilities. And then Uganda Private Midwives Maternity Center, which is a private health unit. So we used a nurses stress questionnaire that has 59 items, but when we adopted it to our settings, we remained with 57 items on a Likert type scale, from never stressful to extremely stressful. So midwives were required to rank their experiences and situations that appeared as stressful or not stressful. And on these questionnaires, we also went ahead after the participant filled the entire questionnaire. We computed a total score for each participant, and this total score helped us to assess the stress level still in the categories, different categories. But also we computed subscales for all the items, and we grouped different items in different subscales. The subscale include death and dying, conflict with physician, inadequate preparation, problems with peers, problems with supervisors, workload-related problems, uncertainty with treatment, problems with patient and family, and discrimination. So we found out that almost 60% of participants were between the age of 20 to 35%, which is not surprising. Uganda has a fairly young population. And also 63% of participants worked in public health units, which means that they are the more predominant health units. So when we computed a total score, we found out that 108, that is more than 50% of participants, reported extreme stress. And then 33.2% reported being frequently stressed, so bringing the total to 95.1%. That is very high, and it shows the stress levels. So among the subscales that came out very prominent that showed high levels of stress included midwives having problems with their peers, problems with their supervisors, workload-related problems, and I think this showed the greatest number, and then problems with the patients and families. So when we compared differences within urban and rural settings, we found that the subscales of death and dying and conflict with physician were more reported among urban working midwives, while the subscales of problems with supervisors and uncertainty with treatment were more pronounced among midwives working in rural settings. But when we compared private and public, we actually found out that midwives working in public health facilities reported more uncertainty with this treatment. The other categories didn't show any differences. So these results indicate that midwives in Uganda, both in public and private health facilities, actually report high levels of stress, which issues actually need to be addressed, and more studies carried out to find out how these issues can be dealt with. Thank you so much.
And I present to you a study entitled Health Workers' Experiences of Care After Stillbirth in Rural and Urban Health Facilities in Uganda, a qualitative study. The other study team members have Elizabeth Ayebane, Tracy A. Miles, Allen Navisere, Tina Lavender, on behalf of the NIHR Global Health Group on Prevention and Management of Stillbirth in Sub-Saharan Africa at the University of Manchester in UK. We know that the occurrence of a stillbirth has profound effects not only on the women, families, and communities, but also on healthcare providers. Lack of training, formal guidance, support, and resources in providing bereavement care has been reported by health workers in other settings. Little is known about health workers' perspectives of this role in low and middle income countries. Our objective is to explore the health workers' views and experiences of care after stillbirth in rural and urban health facilities in Uganda. Now, our study was qualitative interpretive guided by Heideggerian phenomenology. In-depth interviews were conducted on 20 health workers who were nurse midwives, doctors, and midwives who cared for a mother who had a stillbirth, and they were audio recorded, transcribed verbatim, and translated. An analysis followed Van Manen's approach. In our findings, demographics of the 20, 13 were female and 7 male with an age range of 37.5. 10 were midwives, 7 doctors, and 3 nurse midwives. And most of them were midwives, 10, 7 were doctors, and 3 nurse midwives. 10 of them either had a certificate or a diploma, 8 with a degree, and the 2 had a postgraduate. 18 didn't have any training on bereavement care, and 12 of them didn't have any experience of pregnancy loss or stillbirth. About their experiences, they had emotional experiences. They described it as so traumatizing and hard. For example, Agaba from urban settings said, so traumatizing and really hard. That is the major challenge we are facing. The mother is crying, you can't cry with her, but you feel like the tears are coming and that experience becomes too hard. Health workers also describe it as hard breaking the bad news. As Agaba, again from an urban setting, says, it becomes very hard for me to break the news to them. I have no words to express or explain to them what caused the death. And also Peter from a rural setting says it's usually not easy. We need to find better ways of doing it, especially the unexplained death. They counsel the bereaved families, though they at times find it hard to tell them. For example, Rita from a rural setting, I just counsel her generally and I tell her that since for you are still alive, it's God who gave you that pregnancy, you'll get another pregnancy. However, Agaba says they get inadequate information to counsel them and we have no time for them. They also experience system challenges. For example, Darwin and Rita, they say here where we are is small, but we are supposed to separate these women so that they are not mixed up. It's not easy, I must say, because the first thing is we have little time. That's the truth. They also encounter cultural belief challenges. Lynette says that it is a taboo in their culture for the mother to wake up and have a look at that dead baby. So the husband refused and immediately took the baby. Even that, the mother was to first go to her parents for about 3 weeks or 1 month. In discussion, health workers experience significant emotional impacts and system challenges in caring for parents after stillbirth in Uganda. Further research will explore interventions to address these issues, for example, training and support for health workers and improve care for parents. Thank you so much.